So what I'm going to talk to you guys about 5 minutes is an urban legend in emergency medicine, orthostatic measurements. So why do we talk about urban legends in emergency medicine, or urban legends in general, or what are they? They're basically things that we were taught in med school or taught in residency, and if you ever asked the person who taught you, where does it come from? Why do we do it? What's the evidence? They sort of say, well, that's how we've always done it. We've done it like that for years, it works. So what I want to do is take these urban legends and look for the actual truth. What's the truth behind these things? What's the literature that defends them or doesn't defend them? Is there actually any evidence? And hopefully along that way of looking for truth, we will find what's best for our patients. I also am hoping to find how to reduce what I have to do. We're already busy enough, so if we can take something out of the mix, we're pretty happy. So the urban legend we're going to talk about is orthostatic measurements are useful in establishing volume status. And remember, we're not talking about whether they stand up and feel lightheaded. I'm talking about the actual measurements, measuring blood pressure and heart rate, sitting, lying, standing. So why do I care? We see patients with dehydration or blood loss all the time. Orthostatics are one of the venerable tests in medicine, and we want to know if there are patients where this is useful. And probably the better question is for us to ask ourselves, what do I want the test to tell me? And what I want the test to tell me is which patients have moderate volume loss. Because the patients with a lot of volume loss or big volume loss, we don't need a test to tell us that. We can tell them that by looking at the patient. So where does orthostatics come from? It basically comes from this, right? Bloodletting. That's really where the idea of orthostatics comes from. A little bit more accurately, it's taking healthy patients, taking their blood, and then tilt table testing them. That's where we get the idea of orthostatics and the measurements that we're looking for. And these are the numbers that we want to find. We're looking for a drop in systolic by 20 points. We're looking for an increase in heart rate by more than 30 points. So the question is, what about people at baseline? So this is one study looking at, healthy is not quite the right word, they are nursing home patients, but not acutely ill. So non-acutely ill nursing home patients. 900 of them, over 50% had orthostatic changes at baseline. So this isn't they came to your emergency department because they had a UTI. This is, they just went around and did orthostatic measurements on 900 patients in a nursing home that weren't having any specific acute complaints. More than 50% had orthostatic changes. Well, that's an old population. What about young people? So this is orthostatics on kids. 15 to 17 years old. A 15 to 17-year-old is basically an adult, right? Pulse change, sensitivity, and specificity, pretty poor. 61%, 56%. One more study looking at the same thing. Tilt table testing on healthy 15 to 19-year-olds. 44% of them had orthostatic changes. So these patients were not having any complaints, but 44% of them. So what this data tells us, both from the nursing home study and from the adolescent studies, is that lots of people have orthostatics at baseline. If I take the 250 people in this room right now and do orthostatics on them, 50% of you will have orthostatics by measurements, even though most of you are not actually volume depleted, hopefully. So it's really a coin flip, all right, 50%. Basically a coin flip. So how is this useful in actual clinical practice? So there's two questions we're looking at. One is acute blood loss, and one is just other volume loss. So let's look at acute blood loss first. There's no question the patient that was in this room has acute blood loss, right? Nobody's questioning that. What I'm questioning is, how old is this thing? This is actually ultrasound at Bellevue. No, I'm just kidding. So what is the evidence behind here? And again, it's bloodletting. That's where we get the evidence from. So orthostatics done after blood donation. They used actually a 20 beat per minute instead of the usual 30 for increase. So they wanted to be a little more sensitive. So did it work? Under 65, sensitivity 43%. So these patients, we know they had a moderate blood loss, right? We took a unit of blood out of them and then we did orthostatics. 43% sensitive. Over 65, useless. 25% sensitive. Blood pressure changes were completely worthless in this study. They said don't even bother with it. This is an article from JAMA. This is sort of one of those best clinical practices, accumulates all of the evidence behind it. Moderate blood loss, pulse change 22% sensitivity, BP change less than 27% sensitivity. Worthless. Severe blood loss, pulse change 97% sensitivity. Well, great, yeah, the guy who got stabbed in the gut who has 3 liters on the ground, he has orthostatics. Don't stand that guy up, okay? We don't do that. But that's basically what this says. Your clinical gestalt is fine. So let's talk about non-blood loss, right? Other volume losses, dehydration. This is the best study that I could find on this in one of our journals. 23 women with hyperemesis. This is as good as we get for patients presenting to the clinical setting with volume loss. Vital signs inadequate. That was their base conclusion. And if we go back to that JAMA article, all of the evidence collected together, pulse change 43% sensitive, even less specific in those patients that were non-blood loss, volume loss. BP change again, very, very insensitive, not a very high specificity either. So what does this mean? What this means is that if I get a negative result, it is not reassuring. There is still a high likelihood that the patient has moderate volume loss, whether it's blood or fluid, in spite of the fact that the orthostatics were negative. So with this high of a rate, do I really want to waste my time doing this? The bottom line here is that they're overall really not very helpful in determining who has moderate hypovolemia. A lot of these patients have orthostatic changes at baseline, and you can't rule it out based on a negative orthostatic measurements. So if you're going to check orthostatics, I would probably limit it to heart rate alone. But what I would argue is don't even bother checking them. Just stand the patient up or attempt to stand the patient up. If they feel so lightheaded, they say, oh my God, I'm going to pass out, that's good enough. That's really all you need to know. Okay, so I would sit them up first, obviously, because then if they pass out, they're still in bed. But what this really tells us is it's a coin flip. So the next time someone asks you, is that lady with the UTI, is she orthostatic? Just take a quarter out of your pocket, flip it, and if it's heads, say yes, and if it's tails, say no. That's just as good as doing the measurement. Okay, I don't know how many of you guys actually do this measurement. Most of the time, you're asking the nurse to do the measurement. All right, nurses like nothing more than being bothered to do studies that are useless, right? So don't do it. It's one less thing for the nurse to do. It's one less thing for you to do. So the urban legend, again, is that orthostatic measurements are useful in establishing volume status, and the truth is that orthostatic measurements are useless in determining acute volume loss. I think we can fairly say that this urban legend has been squashed. Don't bother with orthostatics anymore. We have a lot of these sort of looks into the background literature behind these things on emlyceum.com. This is the website that I contribute to. It's totally free, no ads, so go check it out. And as I always end my slides, knowing is half the battle. You got to know the literature behind these things, and then you can sort of throw it in people's faces. Thank you very much.